To address the high and rising cost of prescription medications, the government passed the Inflationary Reduction Act. Its goals were to lower prescription drug costs for people on Medicare, as well as to reduce federal spending for medications. In this video, I'm going to share with you 5 very important issues from this legislation that are going to affect you. So the first issue from this legislation had to do with vaccinations. Now, prior to 2023, Medicare would cover certain vaccinations, and these were covered under Medicare Part B, the outpatient side of Medicare. And they would cover the flu shot, they would cover the pneumonia shot, hepatitis B was covered, as well as COVID vaccinations. And all these were covered at zero cost to someone who had Medicare Part B. But beyond that, if there was another vaccination needed, then it was either covered by Medicare Part B or Part D. Now, the problem was, primarily with vaccinations, was the shingles shot. Shingles shot, as you can see, was not in that original list. And so if someone got a shingles shot, it was covered by the Part D plan, but it was usually subject to a deductible, maybe a copay or even co-insurance. So there was a lot of cost sharing involved with this. But with this legislation that began January 1st, 2023 under this Inflation Reduction Act, what happened now, the shingles is still covered by Part D, but it is at zero cost to anyone that is enrolled in a Part D plan. They have to cover the full cost. In addition to that, there were some additional adult vaccinations that were not covered by Medicare B that have now been added to the list. And again, all those are going to be at a zero cost. So in other words, if it's on the list of covered medications now, or as far as vaccinations are concerned, then there will be no out-of-pocket cost to the Medicare beneficiary. Now, the second very important issue with this legislation had to do with insulin. People that have type 1 diabetes, insulin dependent, their pancreas no longer will produce that. Sometimes even people with type 2 diabetes need to take insulin as well. And so Medicare, of course, for years has covered insulin in one of 2 ways. It could be covered under Part B, which is the outpatient side of Medicare, or it could be covered under Part D, which are the self-administered prescription drug plans. And so the way insulin is covered under Part B is when someone uses an insulin pump. And so what would happen is Part B would cover any type of a medicine that requires durable medical equipment for the administration of that. So if someone has an insulin pump, the insulin that's going through the pump would be covered by Medicare Part B. But what happened, the recipient would be responsible for a 20% co-insurance, which could be, of course, very expensive. Now, they could get a supplemental plan to cover that, but the point is it could be quite expensive because of that co-insurance. Now, on Part D plans, prior to this legislation, what would happen? Insulin was covered by the Part D plan, but almost always there was some kind of a deductible with that Part D plan. There could be some type of a co-payment that could be applied, as well as co-insurance. And so what almost always happened, anyone that was on insulin would, because of the expense of this, would almost always go into what we call the donut hole. And so it just simply meant that insulin was very, very expensive, and sometimes so expensive people could not afford it, and they would just forego using insulin, which of course is very detrimental to their health. And so what happened with this legislation is they put a cap on insulin, whether that is going to be secured through a D plan or through Medicare B insulin that's going to the pump. Now the cap is at $35. $35 for a 1-month supply. And so if they get a 3-month supply, obviously it'd be $105. But now that's the maximum, which it will not be subject to a deductible. The copay is a flat $35, cannot be above that. There is no co-insurance. And if someone does get to the donut hole because of their other medications, it would not be, their insulin would not be affected by that. In other words, they wanted to give that fixed cost so people could get their insulin. Now, one thing that's important to note on this is that the government did not require that every form of insulin be covered by every formulary. We may see some changes to that in the future, but right now, plans get to still pick and choose what insulins they are going to cover. But if it's in that formulary covered by that plan, that will be the maximum out of pocket so that people now can afford their insulin. That brings us then to the third really critical issue with this legislation, and that is the expansion of what Medicare calls the Extra Help Program. Some people refer to it as LIS, which stands for Low Income Subsidy. A very important program to really help people that are on low income and have low assets or low resources. And so what we have now are some new qualifying criteria. So prior to this legislation, what happened, we actually had different levels of qualification. So what would happen is someone was at 135% of the federal poverty level or below, they were able to get a full participation in the program. There's full benefit. But if someone was between 135 to 150%, what they had is just simply partial eligibility, which is basically about 50% of the benefit. Well, what they've done with this legislation is they eliminated these two different criteria. Now, anyone that's at 150% or below, all those people are going to get a full benefit. All right, and so this is going to impact millions of people. In fact, this benefit of LIS is actually worth about $5,100, and so it's a very nice package. And so now we have new qualifying criteria. Let me explain how this works now. So what they're going to look at, you're going to notice they're going to look at your income and your resources. And so we have two different types. Obviously, single people or married people that actually live together have different criteria. So the income maximum, this is going to be again 150% of the federal poverty level. If we're at $21,870 or below, we qualify for this aspect of it, married, obviously $29,580 or below. And then they're also going to look at resources. Now, when it comes to resources, they do not count your house, they do not count your car, nor will they count $1,500 worth of money set aside for burial expenses. Those are off limits, but everything else is going to have to count for resources. You can see below 16.6, below 33,240. Now, with these two factors, both qualifying, now we're going to be eligible for the LIS program, which again made millions more people be able to be participating in this program. Secondly, I want to note on this, there are people who automatically qualify, meaning they don't even have to go through the qualification process. And that would be anyone that is presently what we would refer to as a dual eligible person. This means they qualify for Medicare and Medicaid, the state program. So if they're dual eligible, they don't have to qualify. They automatically will be enrolled into the Extra Help LIS program. Also, those that are receiving supplemental security income. This would be people that have very low Social Security checks, and so they get this supplemental security income to give them really an additional amount of money to keep them out of poverty. And so anyone that's receiving SSI benefits, in fact, I think it's about maybe 10% of all people that get Social Security are also on SSI. Again, low income, low assets to qualify for that, but if they have that, automatically enrolled into LIS. Then lastly, anyone who qualifies for what's called a Medicare Savings Program. So anyone that qualifies for the Medicare Savings Program is getting help on their Part B premiums. In other words, they're getting that paid for by Medicare as well as Medicaid. And right now that's $174.70 a month. And so what happens if that Part B is being paid by Medicare, Medicaid, then again, you automatically qualify for the LIS. So what's the benefit of being on this particular program? Well, there's several. Number one is this. People who qualify for Extra Help Notice will have no deductibles. Right now, Part D plans have a maximum deductible of $545 a year. So if someone's enrolled in a plan and they have a deductible and they're on LIS, they don't have to worry about meeting that deductible whatsoever. They'll be at a zero deductible. Plus, their Part D premiums will also be covered. Now, I got to clarify something about this. So when we say no Part D premiums, what happens is the government sets what they call a benchmark rate. And so as long as someone's enrolled in a Part D plan that's at that benchmark or lower, that LIS program will offset the entire cost of the premium. Okay, and so if they're on a plan that the premium is above the benchmark, the government's not going to cover that. So we always tell people, make sure that you're enrolling into a Part D plan that's around that benchmark so that full premium will be covered by the government. Okay, and then lastly, notice this. When we qualify for this plan, we're not going to be subject to the regular copays and the different out-of-pocket expenses that people would have to pay if they weren't on this program, because they set a a maximum cap for your prescription medications. And these would be, of course, 30-day supplies. The most a generic would ever cost you would be $4.50. Now, if the cost of that medication is lower, if it's $3 and that's all you pay, but it would be no more than $4.50 for any generic medication, and it's a brand name medication, which can be very costly, the maximum copay would be $11.20. And so earlier when I said they put the value on this whole program to be $5,100. And so again, if someone qualifies automatically, they're going to get the benefit of it. But if you don't fall into this criteria here, all you have to do is go to ssa.gov. Go to that website, and there will be a place there for you to enroll into the Extra Help program. And it's well worth your time to do that if you fall, again, below or at these income levels as well as resource levels. Hey, if you found this video helpful and you want to see more Medicare information just like it, then go below, right below the video, and you can give us a thumbs up as well as subscribe to our channel. And every time I put a new video, which is about 2 every week, you'll be notified of that video, and others just like you who need this vital information will get it as well. All right, that brings us then to the fourth item that the Inflation Reduction Act has had an impact upon Part D plans and your out-of-pocket cost. And these are changes to really the way Part D plans are going to be structured. Now, on all Part D plans for 2024, we still have 4 different phases. Now, the way to understand phases, if you're new to Medicare, is we compare that to an employer-provided plan or an individual plan that you may have or have been on in the past. You didn't have 4 phases for your drug plan. You had 1 phase, and that would be the plan decides to cover the medication in the formulary. That formulary is given a tier number. That prescription is going to be identified with a certain tier number, tier 1, 2, 3, 4, 5, and that tier number tells us what our copay is going to be. A tier 1 may be a $5 copay, tier 2 may be a $20 copay, tier 3 up. But the point is, in group plans and individual plans that you've had prior to going on Medicare, we just simply had 1 phase. We had fixed copays all year long. They never changed during that year. Whether I got my prescription in January, July, or December didn't matter. I had a fixed copay. When we're on a Part D plan for 2024, we're going to have 4 phases, which means our copayments can change. They actually can fluctuate throughout the year. So I'm going to explain how these phases come about and explain how we move through that system. So all Medicare plans, whether it's a standalone drug plan or it's embedded or integrated within the Advantage plan in 2024, will have 4 phases. Now keep in mind as I share this with you, what was the government's goals when they passed the Inflation Reduction Act? 2 things, was to lower out-of-pocket prescription costs for Medicare beneficiaries, as well as to reduce government spending on drugs. And so they're doing it through this model that I'm getting ready to share with you. All right, so let's start with the phases. Again, we have 4 of them. So the first phase on all plans is the deductible phase. Now this phase is actually a deductible that is set by Medicare. In 2024, that deductible is $545, $545. And all this simply means is in this particular phase, you as the Medicare beneficiary, now look at this. These are the 4 different participants in a drug plan. You as the patient, the one who enrolled in that plan, would pay 100% cost of the medications. Now, if you're on cheap generics that cost $2 or $4 or $5, not a big deal. If you're on a more expensive brand name, big deal, because you're going to have to pay the first $400 and $545. Now, just know this, some plans lower the deductible. Some plans actually bring it down to 0. It just varies. But the majority of them, you're going to have to meet that deductible. It can never be higher than that because Medicare sets the maximum. So my point is, first phase is the deductible. You're responsible for 100% of the cost of your meds. Now, many people will never ever reach that dollar amount. Their meds don't cost enough to get there. And if they don't reach that deductible, then what do? They stay in this phase all year long. Okay, January through December. But if we meet the deductible because of lots of meds or maybe some expensive meds, once we've been out of pocket $545, that will immediately put us into phase 2 called the initial coverage phase. So what's happening here is this. Now notice, the patient, you as the patient, the enrollee in the plan, you're going to be paying 25% of the retail cost of medication. or lower. Sometimes it's just a flat, very reasonable copay, but the most you'd ever spend would be 25%. And what's happening is that Part D plan that you enrolled into or was integrated in your Advantage plan, that plan is actually paying 75% of the cost. You pay 25, they pay 75%. But what's happening in this particular phase, very unique to Medicare, is that Medicare is actually tracking the full retail cost. So the full cost of the drug, you pay 25, they pay 75. And so as they track this retail cost, that retail total of all your meds is increasing. And so if it ever reaches a certain number, they call it the threshold. In 2024, the threshold is $5,030. And again, that $5,030 is not out of your pocket. The majority of that was actually paid by the insurance company. But if we ever reach that number, whether we reach it in July or November or February, whenever we reach it, then we would actually be done with phase 2, and that would put us down into phase 3. Now, this is officially by Medicare called the coverage gap. Unofficially, we refer to this as the donut hole. So yes, the donut hole still exists in 2024. And so what happens in the donut hole, now notice we've got these different players or participants in these plans. And so up to this point in time, it's just been you as the patient, the enrollee, and the Part D plan. But here's where it's going to change. When we get into the coverage gap, what happens? Again, the most you would have to spend out of pocket would be 25% of the retail cost. You're on a $100 medication and you're in the phase 3, you would pay $25. But what has to happen is the plan is going to pay 5%. Remember up here, the plan pays 75%. Now it drops to 5%. And then the manufacturer of that medication is required to discount that medication by 70%. So they're paying 70%, you pay 25, plan pays 5%. So again, that's how we get to our 100%. Now, in this particular phase, we have a different threshold. This threshold is actually referred to as true out of pocket. And this year, that is $8,000. And just so you know, very, very few people ever reach that. They say less than 10% of all people will, but those who do, what's happening? That $8,000 is the manufacturer discount, everything you've spent in this phase, and this phase. All right, so the great majority of that $8,000 is not your money, but it's credited as though you did pay for it because the manufacturer discount is applied to the $8,000. Which means what? You probably at this point in time, they say you've probably spent on average about $3,300 out of pocket. Got it? $3,300. Make that a little bit more clear. Okay, they're saying that's about what someone would spend out of their own pocket. Now, if we reach that threshold of $8,000, we spent $3,300. Now we're in the catastrophic stage. So here's where the Inflationary Reduction Act made a change, because up until this year, 2024, if you're in catastrophic, you actually had to pay 5% of the cost of the medication. Medicare paid 80% of the medication, and then your plan had to pay 15% of the medication cost in the catastrophic stage. And so what's going on here is you still had some responsibility, but very little. But now, with this Inflationary Reduction Act in 2024, all of this has changed. So now what happens is you pay zero. So that's why we're saying the most you would spend in 2024 is about $3,300, because catastrophic 5% coinsurance was then eliminated by the Inflationary Reduction Act. And so what's happening here is Medicare is paying 80%, and the plan that you enrolled in paid 20%. All right? Remember what I said earlier? What was the government's goal in passing the Inflation Reduction Act? Is to make sure that there was some reduction in spending for Medicare. All right? So this is what they're going to do moving forward. So this is 2024. Let's look at 2025. 2025, they've already told us that the deductible is going to go down a little bit, $540. You, as the patient, the enrollee, are still going to be responsible for 100% of the cost up to that deductible. Once you've met that deductible, if you ever do, you'll still go to stage 2. And in stage 2, what's happening is the medication, you pay 25%, manufacturer, the plan pays 65%, and then the manufacturer must discount the medication 10%. So again, manufacturer 10, plan pays 65, you pay 25. But here's the good news. Your 25% now, moving forward from 2025 on, has a cap of $2,000. $2,000. That's the most you would spend for the entire year. And the good news is what they're saying now is that doesn't have to be paid in one lump sum. It actually will be able to be spread out, so they kind of make this transition very smooth for people up to that $2,000. But after that, you can put your wallet away, your credit card, your checkbook away, because after that, you have no expense whatsoever. And so what's going to happen is this. The plan that you enroll in is going to have to pay 60% if it's a brand name medication. The manufacturer must discount 20%, and Medicare is only going to pay 20% now. Remember over here, they paid 80%. So this is how they're reducing their costs. They're moving that to the manufacturer and to the Part D plan. Now, if it's going to be a generic medication, the plan will pay 60%. There's no manufacturer discount, and Medicare will actually pay 40%. All right, so again, from 80% to 40%, 80% to 20% on Medicare side, because again, they're transferring more of this to the manufacturer and those Part D plans. So this is the way plans are going to move forward on 24 and 25. Hey, if you've come to the place where you know you're going to have to make some Medicare decision pretty soon and you want to make the right one of the best ways to do this is to go down below, and you'll see in the comment section there, the very first pinned comment at the top. You can actually click on the link there and you will book a call. And you'll book a call with one of our Medicare guides. All the guides with our company, I have personally trained them. They're professional, they answer all your questions, and they'll show you your Medicare options so that you'll be confident in your decisions. Let's get back to the video. Now that brings us then to number 5 issue of the Inflation Reduction Act, and this really is a major change. When Part D plans came into existence in 2006, it was not possible for the Department of Medicare to actually negotiate prices for Medicare to be able to pull those prices down to save consumer and to save the government. That was just part of the legislation. Well, that has been changed with the legislation. So let me just read the way it used to be prior to this law. There was a law on the books that established the Part D benefit, which included a provision known as the non-interference clause. Non-interference clause, which stipulates that the Department of Health and Human Services Secretary, listen, may not interfere with the negotiations between drug manufacturers and pharmacies and prescription drug plans. Okay, could not interfere. In addition to that, HHS does not currently negotiate prices for drugs covered under Medicare Part B, so not under Part B or Part D. And so there was not possible for them to get involved. Well, with the passing of the Inflation Reduction Act, here's what happens. They're amending the non-interference clause by adding an exception that, listen, requires, before they couldn't, now they're required the Secretary of Health and Human Services to negotiate prices with drug companies for a small number of single-source brand-name drugs or biologics without generics or biosimilar competitors. So single-source just simply means that this is a company that manufactures a medication. They have a patent on that, and they're the only ones that can sell that. That's a single source. And so this would be for small molecule meds, which are chemically synthesized, or biologics, which have a different type of a base, more from a living organism. And so the point is, both types of medications now are subject then to be included in price negotiations, all right, as long as they're single sourced. All right, and so now it's going to be required to this. And again, it's going to be a small number. So this first year, which will be implemented in 2026, will be 10 meds. 2027, 15 meds. 2028, another 15 meds. After that, it'll be 20 meds added to this negotiated list. Why are they doing this? Because remember the goal. The goal was to save Medicare beneficiaries out-of-pocket cost. This is going to help that, but also to reduce federal spending for prescription medications. So let me explain how it's going to work. All right, so this is now the process that's going to be followed to begin drug negotiations between the Department of Health and Human Services and the manufacturer. All right, and so now the first year timeline is a little bit unique, and then year 2 thereafter will be very regimented. But for now, as they introduce this process and this program, what's happening is this. Hopefully you can see this, but the drugs are going to be selected for negotiation. They'll select the drugs, and basically what they're doing is going after some of the most common, most popular, expensive brand name medications. negotiations. And they will publish that list. And again, they just published it just a few months ago, September, that came out 2023. So once that list is published, then what happens is they begin to negotiate these prices. Again, this is the Secretary of the Health and Human Service Department begins to work with the manufacturers in negotiating out what's called a fair market price. And so once the list comes out, the next month they begin this process of negotiating. Now this first year, which is now going on, it's going to be about a 10-month process for them to establish this maximum fair price. And so that will come out. List is established. Right around a year later, those fair prices, then the negotiation is going to end, and then they're going to publish that in September of 2024, and then that list then will begin to be negotiated. Those prices will begin to have an impact upon Medicare beneficiaries, Part D plans, and the federal government beginning in 2026. All right, so this process is a couple years long. And now after that, then it's just going to be an annual process. So look, notice again, they select the drugs, and remember in 2025 they'll do 15 because this one was just 10, and this would be 15 drugs, and then they begin that a month later they're going to begin the process of negotiating and going back and forth and determining what that price is going to be. So the process ends. It starts in February. It's going to end in November. They publish the list then in November, and then that's going to have an impact upon those prices then in 2027. And so my whole point is this. They're going to follow this timeline. So once they've introduced the list at the first of the year, second month of the year, and then in November that list will be published. And then now we're going to start seeing an impact. So consumers are going to save money. The federal government is going to save money by negotiating these particular prices. So we think this is a wonderful benefit that's been added to the Inflationary Reduction Act. So going to save Medicare beneficiaries lots of money out of their pocket, but also save the federal government. All right, so I'm going to close our video out with something I hope will be interesting to you, and that is of the first 10 drugs that have been selected for negotiations. Let's take a quick look at them. Number one, we have 2 medications on the list that are blood thinners, patented blood thinners. This would be for people that may have atrial fibrillation. They have risk of blood clots, and so these medications are actually for that. Eliquis and Xarelto, but notice the money that was spent just last year alone on these 2 medications, over $22 billion. All right, a tremendous amount of money. Now that's going to be up for negotiation, and we'll see that number go down beginning in 2026. And then the next one is for cancer. It's called Imbruvica. Imbruvica is primarily for people that have lymphoma or leukemia, maybe other cancers, but it's either slow the spread of cancer or to stop the cancer. And so again, $2.7 billion spent on that medication. Now the next 4 are diabetic medications, some for type 2, some type 1, but you'll notice Fiasp Novolog, Januvia, Farxiga, and Jardiance. But look what was spent on these meds. We got 6, 9, 16, about $17 billion spent on these particular diabetic type medications. And again, moving forward in 2026, those costs are going to come down for sure. And then we have one Entresto, which is for heart failure. Again, $2.9 billion just for one medication. And then Stelara, which is for Crohn's disease, psoriasis, very extreme cases of that, $2.6 billion. And then Enbrel, which is for rheumatoid arthritis or again psoriasis as well. But in all, this is over $50 billion of medications that were spent just in 10 meds. And the whole program is just a little over $200 billion. And here we have 10 medications that represented almost 25% of the cost that Medicare had to spend for prescription drugs. So you can see why it is that they started with these 10, so hopefully it can have a great impact to save consumers money as well as the federal government. So there you have it, the 5 issues from the Inflationary Reduction Act.